The best artists, innovators, and creators know you can't rush quality. It takes time. Quality doesn't come overnight, from a fluke, or from a split-second encounter. It takes trial, effort, craft, and precision. It never comes from your first question, your first answer, thought, or idea. It takes longer, days, months, even years. Quality is never finished from the first stroke. You have to look, touch, feel, mold, and reshape to find that inspiration, to reach the extraordinary. And from over 20 years of inspiration, we have been perfecting every breakthrough, putting our knowledge, skills, and expertise into our work to become the best in the aesthetic industry. With our German engineering pedigree, our years of experience in hyaluronic acid products and patented technologies, we will continue to invest our time to push the quality of our products, because quality of craft means impeccable beauty. BioScience, the beauty of quality.
Good morning, everyone. I want to welcome all of you. And I'm happy to be here today in this symposium where we're going to speak about the new frontiers, right, with hyaluronic acid already mixed with something. And I want to introduce also our three wonderful speakers. So most of them are from the surgical field, and I'm the only one who is a dermatologist. So Dr. Michael is a maxillofacial surgeon, Dr. Nazareth is a plastic surgeon, and Dr. Marian, which is inside, that she's going to do a live demo, is also a plastic surgeon. So I want to start talking about integration, because when we speak about biomaterials, the one thing that has to come into your head is this: integration. How is my biomaterial going to integrate into the tissues, not into the skin, like people like to say, because we're not going to inject inside the skin. But it has to behave, and it has to be intelligent enough to spread in a way that respects the anatomy. So the retinaculus cutis, the fat doesn't accumulate. So this is very, very important when you talk about biomaterials. So what is the perfect integration? If we would be in an ideal world, the perfect integration is this, right? An external biomaterial is inserted into another one, which is our own body, right? And it integrates in a way that it's so smart that when it goes inside, it becomes something better, hopefully, right? So it integrates in a way where it becomes something else. There's a whole process. It's not immediate. It's a whole process, and it becomes something else. But unfortunately, we are not there yet. So let's think about another thing. Perfect integration. Mitochondria. I'm talking about AJ, and I'm talking about mitochondria, how crazy this is. But think about it. The mitochondria came from a bacteria, right? And it was integrated because the body understood that this was a good thing. It recognized the advantages of having this certain thing, and it was integrated. And now is the drive of our cells. So this is one spectrum, right? This is the ideal. I would love to inject something that my body would say, oh, this is so nice. Let me integrate and creating something else that is better than what I had before. We're not there yet. The other part is the foreign body reaction, right? And this is the other part of the spectrum. Where are we at right now? We want to be in the middle, right? We are not here. We don't want to be there. We are in the middle. We are trying to mimic this type of integration. You're not there yet. So how is the process of integration? So when you're putting a biomaterial, and AJ is also a biomaterial, okay? We don't think about it because it's not particulated, but it is also a biomaterial. So we have an adaptative part that adapts, our immune system recognize it, and for that, some things are key. the shape, how is the gel in terms of hyaluronic acid put, how it distributes, and how the particles inside also distribute, because at some point my body will break the barrier, get contact with the particles, so how it's distributed, it's super important. So biomaterials depends on, the reaction of your body depends on the size of the particle you're injecting, the surface. If it's too irregular, you will induce foreign body reaction. The shape, and also the distribution. So when I inject, how it distributes. Is it homogeneous? Is not homogeneous? So it's not only go there and inject how you injected hyaluronic acid before. You have to think about how the biomaterial or the particles inside are going to sit. Lempert, Professor Lempert, super nice person, and he was curious about this when he studied all the non-absorbable, but also some what they call long absorbable, which was PLLA and CAHA, and they studied it already, and he knows, and he pointed out already how important the surface of the particles are. But again, we know very little about how our body interacts with those things, unfortunately. So this comes from biochemistry, okay? And I was speaking about responsible for the R&D of another company yesterday, and I was saying, look, when I want to study those things, I cannot study any publication on medicine. I have to go to biochemistry, because those are the guys who really study those things in depth. So the mechanism, the biomechanism, or how a cell, the membrane, so it's not so simple. You inject something, you get a result, boom, yeah. But then there's all these cascades we are inducing that we don't understand yet. So there's 36 ports of connection in between a biomaterial and a cell. We don't understand all of them. But I just want to bring this for us to focus on what is important to choose a material and how to use that. So what is our target? What is the mode of action of this product? Because we are speaking about two things now, right? The hyaluronic acid and a particle. It's not one thing or the other thing, it's two things. Both interact differently with the cells. The characteristic of your product, it's not what the company tells you. Say, oh, you go on the bone, you put a bolus, but then how it distributes? If I massage, where does it go, right? How many people you see saying, oh, I had a migration of hyaluronic acid on my face? There's no migration. There's wrong distribution. That's a different thing, right? How it distributes in the tissue and how to be safe when you deal with that. So media like to say and to wash the brains of our patients saying you're looking for collagen. But are we looking for collagen? Point. Or this is just the tip of the iceberg. So what we're looking for when you talk about regeneration is something called the dermal matrisome, which involves not only the GAGs and the proteoglycans and all this involved, but also the cells and also the communicators, which are the cytokines, right? All of this we're looking for. And we are looking for a particulated material that can induce a certain production of collagen in a way, because I always thought that collagen, when you produce the triple helix, that's it, right? There's only one way, but that's wrong. You can produce different collagens with different triple helix, and the chemistry of this triple helix has to be good enough to bond with the elastin, which is the key point for regeneration. Because the elastin will give biofeedback for the body to produce more collagen or not. Scar is a plate full of collagen, but this is not what we want, right? We want balanced matrisome. So this is just an example of a study I did with many years ago, okay? But just to show that when you inject a biomaterial, this is what I want. I want to see no biomaterial in my biopsy after, I don't know, a year, but I want to see more organized, and this is the key word, organized collagen and elastin that respect the biomechanical properties of my skin. And also, I want it to regulate the epidermis and the papillary dermis I want this to be all respecting my architecture. As I said, ideally it would be better than it was before. But at least we have to bring it back to what it was before, not worse. Biomechanically, function. This is very, very important. And for that, and I learned very well this from a friend of mine she's here. She's the smartest person in this, Neve Cardouf, also plastic surgeon from Australia, that the macrophage, as I said, immune adaptation. So the macrophage recognizes the particle surface, and this will induce inflammation, both sides. And then this inflammation can drive you to one way or another way, but all is inflammation, okay? And the fibroblasts will respond to that, creating a more balanced extracellular matrix or not. So how, let's say, irregular the particle you're injecting inside the AJ or the bolus of your AJ is, this is how your body will react to that, creating balanced or not balanced. So those are the biomaterials we have in the market. And you see that some of them are irregular, porous, and all this make a difference. And I'm not speaking badly or good, better of one or the other. I'm here just to say that there's different things. You have to know how to use each one of them in the best way possible. This is how it looks like in electron microscopy. So you see that PLLA, it's highly irregular, right? What we have right now, there's another PLLA coming that is round. But for now, what we have mostly in the market, they are irregular particles. They will induce a different pathway. All of the other ones are more round. What is the difference? Some are porous, and also the purity of the material. If you have a broken material inside, that means you will have irregular particles. Also make a difference. The distribution inside. When I did this study, I didn't study DX because I didn't have access to that. But I studied most of all the biomaterials that we have, in particulated materials we have in the market. And you see how they distribute differently. So I cannot use the same technique for all of them, right? They are not going to behave the same. If I use the same technique as I used, even if I dilute the material, you look at PLLA, get accumulated. You look at this, this is caprolactone, get accumulated. It doesn't behave like other materials because the vehicle is different. And even if the vehicle is different, the marriage in between particle and vehicle are different. So you see the distribution that I ideally want on a product is that I inject subdermally. And this is not DX yet. DX is going to see in the end. But this is ideal. So it's a homogeneous approach subdermally, and it goes down on the fascia. It reinforces the connection in between my mass and my skin to keep the skin envelope tight. This is different than this. This is another biomaterial that, although I dilute it and I try to massage and etc., it gets accumulated. You see the bioparticles and the particulated material inside gets accumulated. It was the same amount, 0.2 ml, 0.2 ml in a retrograde injection with the same cannula. Look how it looks inside. Completely, absolutely different. This is AJ with CAHA. Yeah? So my point is not that one is bad, the other one is good. I'm just saying that you have to know how to use each product differently, and you're going to see that DX behave completely different than both of them. So AJ is a different thing, but we have to understand that the AJ, which is the vehicle that carry my particles, you have to understand how it is, right? Each one of them is different. So if you put AJ, simple AJ, okay, in different layers, it will behave differently. You're going to see Marianne injecting deep and superficial to distribute as a retrograde, and in the depth to create volume in bolus. So what I'm saying is that AJ, if you put in the same way in different layers, it will behave differently because the tissue is different. You see a CAHA with AJ also in the depth and superficial is different. But some AJ with CAHA, when I put deep, I put a bolus, I massage, it lost the projection effect. That means the AJ part is not doing its part of lifting, right? So it's not good for augmentation if you want to correct a contour, for example. If you put on the surface, my ideal is that when I inject in the surface, it will distribute homogeneously and it will reinforce the connection in the retinaculus cutis. It's not happening. This is not ideal for what we want for this technique with cannula. So what I'm saying is that what we're looking for here, and what we're going to see Marianne doing, is something different than this. And this is how materials in 6 months looks like in a surgery. So this is Caja with AJ. Look, the accumulation you saw before, how it looks like in a surgery. And this is PCL or caprolactone. So what is the secret here? That the particles inside the material get distributed enough that you don't have, when you see in the ultrasound, and you're going to see the X is a little bit different, so, or very different, you're going to see that you don't see that hyperechoic signal simulating for you or indicating for you that the particles are so tight together that they're reflecting completely the light of the ultrasound or the sound of the ultrasound. Okay. Another thing we have to take into account is that when we try to do chemistry by ourselves, it doesn't work the same as products separately. So this friend of mine tried to imitate the hybrid fillers you do with the hand, right? Mixing things. And it doesn't stimulate, doesn't get the best of both of the things you're combining. So the regeneration you have with both separate is much better than combined. So to mix with our hands sometimes or play the alchemist is not the best. So we have to look for products that are already mixed and already tested. That's my point. But we can have complications, right? So you have to know how to use your products perfectly. So you can have product accumulation. This is Caja and AJ. This is PLLA. And this is dextranorm, but injected old ages ago, because I only found this one from, I don't know, many years ago, this publication. They used in the glabella, and most probably they put too much product in a wrong place. When you have muscles interacting, it's quite complicated to have particulated biomaterials, because you can induce foreign body reactions for the accumulation, because imagine that the muscle will bring the particles together. So deep knowledge of your product. You have to get deep. So when they offered me to work with the product, I said, okay, I have to inject in abdominoplasty skin first and see how it behaves to decide what is the best technique for this product, because it behaves different than the other one. You're going to see in my last slides, I put how it behaves. You have to be proactive. You have to know what you're using and be proactive. If you think you're injecting in an area, I always call my patients, every injectable patients, in the next day to see if they are okay, if there's any lump, if there's any reaction, and I want to see them. And you have to have a good technique. And don't forget that regeneration is the ability to recreate. We don't want a structure that also loses the function. We want to respect the function. Thank you very much. And I want to call Michael. So he's going to speak about the anatomy and the safety, and he's going to be linking with Marianne also during the live injection.
All right, Gabi, thank you so much for the introduction. Good morning also from my side. I'm super excited to be here together with you. Thank you also for the invitation. My name is Michael Alfertshofer. I'm based in Berlin in Germany, and I'm specializing in craniomaxillofacial surgery. Over the years, I have been doing a lot of facial anatomy research also together with Gabi. So I'm excited to provide the anatomical basis for the magic Mariam will be doing in a second. So before we start off with the anatomy, I would like to quickly focus on the product, since product choice and anatomy always go hand in hand. So with Genefill, BioScience is aiming for a dual effect. On the one hand, an immediate effect through the volumization with HA, and on the other hand, and Gabi explained this very nicely, a collagen producing effect. And it's the combination of both that in the end can last long and cause longevity and good aesthetic results. Now, for the live injection, Mariam will be focusing on the mid phase and the lower phase. And the mid and the lower phase are massively dictated now by 3 regions. That's the malar region, the jawline, and the chin. And all of these 3 regions are again massively dictated by the underlying bone. So you will see a strong emphasis on deep injections to recreate this bony contour and to again recreate the contour of the mid and the lower phase. Now let's start off with the mid phase. The mid phase can be quite complex when it comes to anatomy, but rather than focusing on all of the anatomic structures and knowing what they're called and in what relation they are, it's more important to understand the basic principles. And I think the basic principle of the mid phase is to understand that the mid phase is not just one mid phase, but can be separated functionally and anatomically into a medial mid phase and into a lateral mid phase. And the concept that is separating the mid phase into a medial part and into a lateral part is the so-called line of ligaments. We have published this many years ago now. The line of ligament consists of 4 ligaments, basically the temporal ligamentous adhesion, the lateral orbital thickening right next to the eye, the zygomatico-cutaneous ligament on the zygomatic arch, and the mandibular ligament right in the jowls region. Those 4 ligaments are the strongest ligaments we have in the face, and basically if we now connect them together, we can see, like this red line, that's the line of ligaments that is separating a medial part of the midface from a lateral part of the midface. Now, this is not some random anatomical division of the midface, but also holds clinical implications, because when we take a look at the medial midface, we notice that all of the facial muscles are basically located there. The lateral midface, however, does not hold any major relevant facial muscles, so maybe some fibers, but nothing too crazy. So this also means that our 5-layered arrangement of the face, typically consisting of skin, subcutaneous fat, the muscle, deep fat, and bone, is disrupted and is different in the medial midface and in the lateral midface. If we now take a closer look at the zygomaticus major muscle, you will see that the muscle is starting off deep on the bone, obviously from the zygomatic arch, and is inserting more superficially into the modulus right next to the mouth. So that means we have a transition from layer 5, the deepest layer we have in the face, to a more superficial layer, layer 3, the so-called SMARS layer. And due to the fact that the muscle is now changing orientation and changing layers, we termed this arrangement the roof tile arrangement, because just like in roof tiles, the muscle is coming from deep and ending more superficially. On the other hand, now if we take a look at the lateral midface, we see that we don't have any muscles disrupting this layered arrangement. We basically have layer on layer on layer, and that's why we call this the onion layered arrangement, because we don't have any muscles that interfere with this arrangement. So to sum it up, the medial midface roof tiles, because muscles are coming from deep and inserting more superficially. In the lateral midface we have those onion layers, parallel layers with skin, subcutaneous fat, muscle, deep fat, and bone. Now, obviously, these anatomical differences also hold clinical relevance, because in the medial midface, this is something you see in everyday clinical practice, tissue tends to be firmer, it tends to be more tightly interconnected, and this is due to the fact that we have our muscles. Those muscles are holding the tissues together, basically, and that's also the reason why we should place our product in the medial midface if we want to achieve a volumization effect, because the product stays where it is. On the other hand, in the lateral midface, we have tissue that can be more easily redraped. You can feel this for yourself. The lateral face is easier to move, and that's also the reason why lifting in this facial region is more easily done than volumization. Now, this is one clinical implication. We've done many different studies on the differences between the medial midface and the lateral midface, also in positional changes when standing upright and laying down. So we see that there's a difference in the midface when we compare medial to lateral. Now, the recommendation to place our product deep in the midface is also backed up when we take a look at the vascular anatomy. So we all know this illustration from med school with the facial artery and the facial vein starting off deep laterally on the bone and ending more superficially in the medial midface. Now, this is, at least from my own personal experience, only partially true, because in this illustration you can see that the facial artery and vein are coursing together like twins and do not separate their course. So, as I just said, personally I've never seen them run like twins, both in the dead specimen as well as in the live patient. I have made the experience that the facial vein is taking almost a vertical approach towards the mid-pupillary line, while the facial artery is going more in a 45-degree trajectory towards the modulus. So basically they're diverging. This is bad news for us because now we have to be aware of the facial vein and the facial artery and cannot anticipate that they're located close to each other. And to make things even more complicated, we can now talk about branching patterns of the facial artery and so on. However, in the end, this does not tell anything about our patient and the vascular anatomy. Therefore, I propose to just keep it simple when it comes to the facial artery and respect that in the beginning, they're running deep on the bone and becoming more superficially. So if we want to treat the jawline, it would be a good idea to stay on the other side of the soft tissue and therefore more superficial in the subcutaneous layer, while in the midface, if we know that the facial artery is coursing superficially, let's just stay deep on the bone. Now, when going deep on the bone in the midface, however, we also need to be aware of the infraorbital foramen. The infraorbital foramen now is pretty consistently actually located in the mid-pupillary line, and even more important than that is to know that the infraorbital foramen along with its vessels does not point like this in a 90 degree to the bone surface, but rather shows an orientation towards the nose and mouth, and in the end we want to avoid piercing that foramen. So if we hold our cannula like this, we would be basically going into the foramen, so just tilting it in the other direction is something we can easily employ in our injection techniques to minimize this risk of inadvertently hitting the foramen. Now, the lower face is forming an aesthetic unit with the midface, so I think it makes sense to talk about them in one session. For the lower face, I have good news. Anatomy is way more simpler than it is for the midface. We can strictly adhere to our 5-layered arrangement. For this, I prepared a dissection in which you can see the skin as the most superficial layer, followed by the subcutaneous fat. And you can see very nicely how this is an avascular zone, so we do not anticipate any major vessels. Now, when I'm flipping over the subcutaneous fat, you can see some reddish fibers. That's the platysma. So in this specimen, I didn't separate the muscle from the subcutaneous fat because they're very tightly interconnected. And below that, we can already see the bone with the facial artery and the facial vein. Now, for those of you who just looked very closely, you might have noticed that the subcutaneous fat, so layer 2, looks different in the jawline than it does in the chin. And that is because we have a change from a type 1 to a type 2 subcutaneous arrangement. So this is already quite advanced when it comes to anatomy, because type 1 is found in the jawline. Here we can easily separate the subcutaneous fat from the muscle. They are not really tightly interconnected. However, if we go anteriorly towards the chin, we can really see how it's a strongly interspersed meshwork of muscle and fat. And this is also something we see clinically because the chin just feels different. And this is due to the fact that the mentalis muscle is coming from the bone and is really inserting into the skin, basically traversing all the layers. So it's just one big meshwork. This is something to keep in mind when doing volumization, because product tends to stay in this area of the face very nicely since it is so interconnected. So for the vessels in the lower face, we've already talked about the facial artery and the facial vein. However, instead of talking again about the facial artery and the vein, I would like to draw your attention to the biggest branch of the facial artery, and that's the submental artery. So the submental artery is just like the marginal mandibular branch of the facial nerve, coursing along the mandibular margin and is giving off one clinically significant branch, and that's the ascending mental artery. The ascending mental artery is going in a paramedian layer, a paramedian plane towards the inferior lip. Now, this artery coming off of the facial artery, as well as the mental artery coming off of the maxillary artery, are now arteries we should be aware of, because right on the bone they are forming many different anastomoses. On the one hand with the inferior labial artery, also from the facial artery, with the lingual arteries, sublingual arteries, you name it. So we have a lot of different connections and a high vascularization. So why is this now important? We're always talking about vessels in the glabella and the forehead because we want to avoid the risk of vision loss. But in recent years also a very interesting complication has been reported in regards to tongue necrosis. So in their case series, some Thai authors described that after sharp chin injections right on the bone, tongue necrosis occurred, and the reason for this is that in chin injections we might end up hitting the ascending mental artery. In this illustration you can see how the yellow HA bolus is traveling along those anastomoses and ultimately ending up in the tongue. So we can have tongue necrosis on one side or both sides. So this is something we can hardly avoid, to be fair with you, but something to keep in mind, and also something we should make the patients aware of, that this is a complication that might occur. All right, so that's it from the anatomical point of view. I'm looking forward to seeing what Mariam is doing. Thank you so much. So first of all, from what I've understood, I'm supposed to show the slides of Mariam, and then we will go to the live transmission so she can show her injection technique. So patient model today will be a 26-year-old female, and the reason why she is receiving treatment is that there is a certain imbalance between her right and the left side. So the left side is the one being treated, and in order to, create a harmonious symmetry. For this, these are the markings. So the red dots indicate the zygomatic arch, as well as the mandibular angle and the gonion. And these are also the points in which we are injecting our product to provide the volume. Same goes also for the other side. The red dots indicate the bolus placement, and the blue arrows indicate the line threading of the product. All right, Mariam, let's hear it.
Do you hear me my voice?
Yes.
Yeah, perfect. Hello everyone, thank you Gabriela and Michael for amazing presentation about product anatomy, because there is really important while we deciding to inject the product on the patient's face, we need to understand first anatomy and the product itself, how it integrates with tissue, because the result will be effective and safe. It depends all these topics. So today my patient, as you can see, is quite young patient. She looks beautiful, but as you can see, and Michael also mentioned, she has a little bit imbalance between both of sides of the face. Right side is more fulfilled, and as you can see, she has quite strong masseter, but unfortunately she is not responsible on some botulinum toxin injections. That's another problem of her. She also had some dental problem when she was a child. So another thing is that on the left side we have a little bit more sunken tissues, which looks like atrophied tissue. So in case we want to achieve the balance and harmony on her case, I decided to do some beautification, because she's young patient, she don't have a saggy skin, she don't have a ptosis, right? So what I'm going to do is just to use a few techniques which highlights her cheeks from her mid-face and as well the lower part of the face. For this, of course, I'm going to use Genefill DX. My working area is two-layer. I will use for the working areas. First is I will inject deep to the bone of the zygoma, and then I will inject superficially to highlight the cheek. What is important when we talk about mid-phase and when we're injecting, it is really important to take into the consideration, as Michael already mentioned, the anatomically danger zones, because we don't want to get some adverse effects and complication. That's why I'm choosing more or less lateral part of the zygoma, because here on the medial part, I have quite important structure that I want to avoid in case of create the volume. So here we have a facial vein and we have infraorbital foramen, which is covered by artery and nerve. This is what we want to avoid. So that's why my working zone here will be more lateral part, and we know that mid-face is quite mobile area, especially when we talk about superficial fat. That's why you need to choose the product which can be structurized with the tissues while the patients are moving her face. So what I'm going to do is that first I will use the needle for the injection on the bone to get more projection, because as Gabriela mentioned, the Genefill DX does not has only biostimulator effect, it's hyaluronic acid as well with dextronomer, which helps us to get more volume because of bulking agent, that it pulls more water. That's why I want to get some volumization points for the mid face. So how I'm defining my entry point, here I'm finding the zygoma bone prominence, and smile please. Yeah. And then I will mark my first injection point where I will use my needle. Then I will mark my second injection point, and probably I'll use also the lateral one a little bit to get some lifting effect. And then afterwards, with the 25 gauge of cannula from the lateral part, I will inject into the second layer subcutaneous fatty tissues to get more highlights on that respective area. Then what I'm going to do is a little bit to elongate the chin. She has nice chin. She has a little bit of hyperactive mentalis muscle. But what I like to do on her is slightly elongate the chin, because we know that it affects on the jawline as well. So my entry point here will be inferior border of the bone, because I don't want just to project it, I want to elongate it. So that's why I am going from here to inject. Then for the gonion and jawline, I'm not going to use much product for the right side because she itself has quite bulging. I will just contourize it a little bit bolus. I will introduce to the gonion through the bony part. So how I'm marking my entry point with my finger, I'm localizing the gonion. In young patients, it's usually easy to define because they don't have absorption of the bone. So, and easily I will go through the bone. And just remember, if you are injecting it, you really need to be sure you are on the bone. And then from my anterior part of the masseter, I will have my entry point into the subcutaneous fatty tissues, because we know that here in the deep to the bone underlies the facial artery and vein, which we don't want to actually touch. That's why I will go in the safer area, which is subcutaneous fatty tissues, and I will do some contouring of the jawline. And probably I will also, from this entry point, go a little bit through the in location of the chin to get more projection as well to the anterior part of the jaws. So thing is that here we have quite good structured fatty tissues. Here we have a less. That's why Genefill DX gives me possibility to create this structure and get more projection. Afterwards, then another speaker will start to talk, and then I will finalize another side of the patient. So I will just quickly wear my gloves, and let's start the procedure. So, of course, it is important. Even you doing injectables, you really need to think about aseptic rules, because sometimes if you are not cleaning the face of the patient, you can really achieve some adverse effects. So, Genefill DX, which is 1 ml in the syringe, it is in the box included 25 gauge needle, which is perfect for the injection. So, what I'm doing first, I'm releasing a little bit product, but of course not too much, do not waste them. And first what I'm going to do, I will take my marking point, as with the needle I will go to the bone. So here, when you are on the bone, you feel you are steady. So me in my practice, this is my practice, not aspirate too much, but of course there is a studies that's better to aspirate and it always makes sense. So please aspirate and just count approximately 8 seconds, because if you get the blood into your syringe, it means that you need to change the direction. So here I will insert 0.2 of product. So with low pressure, because this is quite high G prime product.
That's all right.
And then I will just, can I have a, So here I prefer just to get one injection point, not to go like to the another, to another tissues, because here I just want to volumize it.
Gabby, you want?
Then what I'm going to do, I will put my another puncture a little bit anteriorly, 0.8 centimeter or 0.7 centimeters away from the first injection, and then, okay, let's do it. So, and then here, feel that you are on the bone. Of course, here I will put a little bit less product, approximately 0.1. I have amazing patient. She's not complaining about anything. Okay, and the last one, because you know here we always say that hyaluronic acid product, especially like Genefill, they are like glue. They are helping us to create the camouflage, to highlight and leave the tissues. Yes, yes, Michael?
Okay, so Gabi just asked me what gauge needle you're using.
25 gauge. 25 gauge of. And look, when I'm injecting, I always elevating the tissues because I have to achieve as well as lifting effect. And there we go. Here we are. After that, I will use 25 gauge cannula to 25 gauge cannula to highlight my cheeks, and my entry point will be along the zygoma bone into the subcutaneous fatty tissues. And, sorry. Here we are. So how we understand we are in subcutaneous fatty tissues, our cannula is mobile, and you always can to touch the tip. So here I am. This is where is my cannula at this moment. This is my tip. And what I'm going to do is just a little bit to touch the tissues, because she has acne scars as well, which of course creates the quite rough connective tissues. So what I'm going to do is just I will use the product retrogradely, because the Genefill is high G prime product. Of course, it's not too easy just to slide. That's why we need to just push the product, but with low pressure. I will do one more and we will done. I'm helping the tissues to be there is. When we are in subcutaneous fatty tissues, here, of course, we are more or less safer because we don't have some big structures as a big calibers of the arteries and vein. Okay, for the mid phase we're done. Now we will continue to do the lower phase. First I will inject the chin, and then let's continue to inject to the yeah. Okay, regarding the chin, as I mentioned, I'm going to elongate a little bit. Here, as Michael mentioned, to the inferior border, we are not in the danger zone. We can work on the bone freely. So, can we start it, Tavi? Yeah, good. This. Tavi, more. Just pull up. So what I want to do is, as I mentioned, to get more heart-shaped face for her. That's why what I will do is I will inject my needle to the bony part. Here I'm steady, I'm feeling I'm on the bone, and then I will inject my product. Yeah. Here I use a 0.1. I will add a little bit as well, and then there is. I'm on the bone, and here we are.
Can you hear me? Mariam?
Yes.
Can you hear me? Okay. So we are a little bit short in time, so I'm going to ask Nazaret to start her presentation, and then you continue, and then we go back to you to see what's the difference in between the sides, okay?
Okay, okay.
I want to call Nazaret. She's plastic surgeon from the north of Spain, and she's going to talk about the clinical applications of what we saw.
I want to talk about this product, Genefill DX, to introduce you to it. Thank you very much to BioScience to invite me to be here. The development of this product is innovative. For me, it's one of the best products in the market today, and you are going to see why. No, it doesn't work. Okay, here. So Genefill DX is a product that there's nothing compared in the market. It is a product that have two functions. One of them is volumization, like HA, but we are going to use it with another particle. It's called dextranomer, but it produces a rejuvenation because a biostimulation of the tissues. Here you have DX. We have a cross-linked hyaluronic acid inside. 14 milligrams of this product is biphasic hyaluronic, and we have microspheres of dextranomer with 15 milligrams of product. This dextranomer is going to make a scaffold inside the tissues where the hyaluronic acid is going to go inside. So we're going to have a prevention of the migration of the product, and we are going to have a long-lasting result in volumization because the hyaluronic acid in our body is not going to dissolve this hyaluronic acid too fast. So we are going to have a long-lasting effect, and we're going to have the volumization in the place we really want because we are not going to have a migration of the product. The dextranomer is a glucose, is a biopolymer that is resorbable and hydrophilic. This product is going to make this volumization of the tissues, and it's going to produce a biostimulation and regeneration of the skin because it's going to produce collagen in the body, not only one type, different types of collagen. It's going to induce the production of elastin and modulation of the key cytokines. This modulation is going to produce a regeneration of the tissue, but without inflammation. So the collagen is going to be structured and not like Gabriela told us before. It's not going to be a scar. It's white, you can see in when Marianne used it, so we are not having to have Tyndall effect, and have a property, very balanced viscoelastic properties, so that's going to be a very, very good result. We are going to use this product for harmonization of the face, in every part of the face. But the approach is going to be different if we have a man or if we have women, because we don't need the same, but we need to know where are the needs of our woman or man to know exactly where we need to inject it. When we have a woman, we need to have a rounded volumes, because we need something that is elegant. We need to be more youthful, but we don't need a lot of volume in everywhere. We need to pay special attention to the cheeks and to the lips, but we can inject in other parts of the face to make this harmonization, to get this symmetry that is very elegant and very attractive. With age, we are going to have a loss of bone in different parts of the face. So if we inject this product in these parts of the bone, in the zygomaticomalar area or in the mandibular area, we're going to have a repositionation of the tissues that it's going to sag with age. We will have a very good structure, and everything is going to go to the correct place to have a youthful appearance. So we are going to inject it in the medial part of the face, and we are going to correct the dark under the eyes, and in the chin or in the mandibular area to have a very good cervicofascial angle to make a youthful appearance. And with this, the results are going to be very good with the time, with a very good satisfaction in patients or in doctors. When we have masculine approach, we need to know that we don't want rounded effect. We want angles in our patients. We need to an angle mandible and square chin and a very marked zygomatical area bones. We can see here the results and how with DX we can have a very long-lasting result with the product injected in the place where we really wanted to inject. There's no migration. And I want to present you the preliminary results of a study it's ongoing. It's an echographic study, because with echography we can see how the skin is. We are going to evaluate the dark band that it's behind under the epidermal that you can see is white, and if we evaluate here we can see exactly how many collagen fibers we have. When we have a very old skin, we're going to see that this dark part is very, very black, and when we have a stimulation with more collagen or in more young patients, we're going to see this is not as black, it's more white. So we are evaluating with artificial intelligence how this band, this dark band, is evolutionation with the DX. We have some patients, and in the first month, the evaluation, we can see that there is an improvement of the quality of the skin. We can see objectively that there is really a collagen production in our patients, and their skin is more young than before, it's younger. And why are we doing this? Because in this patient, 6 months after the treatment, you can see, of course, there is a lifting effect, but you are seeing that her skin is better. It's better skin because of the collagen. But we want to have results objectively, not only my subject appearance of the parents. So Genefill DX is a part of the new generation of fillers, and for me, it's an ideal choice to have a natural look, because it has not only a lifting effect, because of the regenerative effect of DX. Thank you very much, and we are in a rush, so we need to run a bit.
Thank you, Nazareth. But I'm going to quickly show something. So I was very interested, and I don't have a vast experience as much as I have with other products, But I found it very interesting that when you inject superficial, and I want you to have a look how it looks like. So there's one thing that caught a lot my attention. So do you see that it has the same pattern as the normal fat? You almost, it looks invisible, right? I injected it and you cannot see it. If you inject deep, it's a little bit different. You can see the bolus, but also when you see the bolus inside, and this is a 0.4 ml, I never use bolus this size, but I needed to have a big bolus to try to see the pattern and to try to compare. And what I saw is that, do you see inside and you see the fat, how it looks like? In my ultrasound is quite good, and this is a really big augmentation of the 25 Hz. So, I mean, you can see even the dots, right, in the dermis, and the band that she said in this ultrasound is really clear. But this is abdominoplastic skin, okay? I just wanted to see the behavior of the product. What caught my attention is that the particle inside the product is very well distributed. There's no accumulation. Do you see what I'm saying? This is key for particulated materials. And this is why this product caught my attention. So when you see superficial, you see that you inject in a bolus, but when you massage, it spreads. This shows intelligence of the product, because it doesn't get like a blab when you inject superficial. But when you go deep, when you massage, you almost don't see the product, right, exactly where it is, but it stays as a bolus. Lose very little the lifting capacity. So this is an intelligent product to do a double layer like Marianne did. So for me, it's very, very interesting, and I want you to compare with other AJ with another polymer, but just to show the difference in distribution, understand? So do you see the accumulation of the particles? You see the white look. Obviously, the reflection of caja is completely different. When I inject radius, it's also different, but it goes around anatomically. With AJ, the key point is how the particles distribute and how tense, how cohesive this AJ is in the different layers, right? So when you see in the depth, the important thing is to keep the bolus together. It's not going to be as regenerative as you are in the surface, never. But what Nazareth showed is what we see with polymers. When you inject subdermally, you are hitting the hypodermis. And we are enhancing some pathways with the epidermis, because what she's showing is the improvement of the elastosis on the division in between epidermis and dermis. So this is something we are not aiming directly with the product, right? It's a secondary effect of the work that regeneration is doing. So this is something very, very important. And I just wanted to augment to show you that there's no accumulation of the particles. And this is the most important thing. I like this phrase of Ernest Hemingway that when he says that there is 7/8 of the iceberg that is under that we don't know. We're only seeing a tip. So regeneration is this. Regeneration knowledge nowadays is like the iceberg. We know the tip, but it's a lot more inside that we don't know yet. So I just curious to see the next years.